So this is a collaboration here with Serena Horovitz in the institute from Mark Hallett, and it's about layer fMRI in clinical populations. And there are many reasons to do layer-dependent fMRI in clinical populations, and there are quite a few review papers out there, but until now, there's not much data available yet. There are a few studies starting, for example, Pang Cheng, who is part of this call now, and their amniotic patients are getting some data, but also we want to get the first-hand experience and learn the challenges and the capabilities of layer-dependent fMRI in clinical populations. The obvious challenges in clinical populations here looking at focal hand dystonia patients are obviously motion. Those are not trained participants. So we have different epochs where the participants move quite a bit. So we need to learn how to deal with that. Then also with respect to the task, they're not so compliant or they're not as much trained as the conventional participants that we are used to. For example, here it's hard to see, but this participant is asked to move the ring finger. And you might be able to see that all kinds of fingers are moving, which will reduce the finger-specific contrast to noise ratio of that specific task. And also in patients, we don't really have so much time to optimize the acquisition protocol when the person is in the scanner. So we kind of need to live with all kinds of imaging artifacts. So we developed this kind of semi-automatic alignment setup where we align the different patches of the different epochs when the participants did not move so much towards each other. We also use all kind of laminar and columnar smoothing tools dependent on the hypotheses to deal with the lower contrast to noise ratio. And we use this blood volume sensitive VASO method, which has label and control images and thus inherently kind of normalizes some of these imaging artifacts away. So here you see the 0.75 millimeter in plane resolution blood volume sensitive activation maps in healthy hemispheres and the hand dystonia affected hemispheres. And this is just to convince you that we indeed do have enough baseline activation to work with. To analyze those slab data in a topographical fashion, I'm using the new tools developed by Farooq Gulban that he developed as part of the layer fMRI software suite Laney, which allow you to use kind of any limited field of view 3D MRI patch, and then you pick a seed region as an origin of your coordinate system, and Farooq uses all kind of flooding tools and algorithms to span an orthogonal coordinate system in the distorted space of the folded cortex. And here you can see that you can then easily analyze those data across cortical depth or across topographical dimensions here for layers and columns in the folded or flattened space. Here you see how this is applied in the sensory motor system of the focal hand dystonia patient. So you see this kind of orthogonal coordinate system, which is less easy conceptualizable in the kind of the projections of the axial view here, for example. So then in the flattened cortical surface, for example, here in the middle column, you can see that for the healthy hemispheres of the hand dystonia patients, you see these nice and concise located finger representations in a kind of somatotopically aligned fashion. So neighboring fingers are represented neighboring in the cortex, whereas for the hand dystonia affected hemisphere, it's kind of all messed up. There's a lot of overlap. Even though we have a lot of signal, it's very hard to see clear patterns there. Maybe even more interesting, when we look at it in the layer space here for blood volume responses across cortical depth on the top left, you see that the affected hemispheres have very clear increased activity in the superficial cortical input layers as compared to the deeper cortical spinal output layers. This is different in the affected hemisphere in blue compared to the healthy hemisphere in green. And this layer dissociation can be seen also in blood volume sensitive VASO as well as in gradient echo bold. And hand dystonia experts have told me that such layer-dependent modulations would make sense because there are many competing disease models about the origin of focal hand dystonia, and some of them predict that hand dystonia disease is mostly coming from insufficient surround inhibition, which we would expect in the superficial layers. So due to reduced inhibition, we have increased activity in these superficial layers, which does make sense. And with this, I thank all my colleagues and I thank you for your attention.